You. Hi guys, good afternoon. I'm Dr. Kohli. For those who haven't met before, I'm one of the hospitalists here at West, and thank you, Chief, for inviting me again to do this lecture. The topic we're going to discuss is heart failure management, predominantly in the inpatient setting. And thank you for keeping your video cameras on because I'm going to try to keep it as interactive as possible and ask you simple questions, nothing to be scared about, just to make sure everyone's kind of enjoying this and not snoozing at the background. Sound fair? So if I call out your name, please just try and answer the question, okay? Okay, let's start. So heart failure in the inpatient setting. Before we go any further to discuss heart failure in the inpatient setting, we need to understand where do the symptoms of heart failure come from and what's the basic pathophysiology behind it. We need to recognize that the two major pathophysiologies, how the symptoms occur, are fluid overload and a decrease in cardiac output. And the two basic categories, which I'm sure all of you are aware of, is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Again, I'm sticking to absolute basics. Reduced ejection fraction causes are more like ischemic cardiac disease, anything which would cause structural damage to the heart, whereas more preserved ejection fraction causes are to do with the difficulty in the ventricles to relax, which are more long-standing, like hypertension, diabetes, obesity, thyroid diseases, etc. In some cases, you might have features of both systolic and diastolic, and a new terminology which is slowly coming into the in favor is heart failure with modified or mid ejection fraction for between 40 to 55%. But for the purpose of this lecture, we'll try to keep it at the basics, reduced and preserved. So at this time, the first person I see on my list is Tina. Hi, Tina. So Tina, can you tell me how do you classify heart failure? Other than this, we've talked about this. Any scoring scale or anything you know on how to describe the symptoms of heart failure?
I know I've heard like the New York Heart Association classification, which is based on like functional status. And I remember there are 4 different tiers, but I don't remember exactly.
That's perfect. Thank you. So let's ask Marie. Marie, do you know the 4 different tiers of the New York Heart Association, the NYHA classification?
No, at this point, I can't give more information than Tina.
That's perfectly fine. Let's try maybe Dalit knows. Dalit, you want to try that one? The NYHA classes or the classification is?
I don't remember exactly, but I do remember that it depends on how much they take to tired and how many blocks they can walk, or like how many pillows, and it's 1, 2, 3, 4, and 4 being like basically at rest.
So you're close. You're in the ballpark. So, so the two basic ways of dividing the symptomology or the severity of symptoms are the NYHA and the ACC classification. Galit, you were right. The NYHA classification looks at more about the functional status. And the easy way to remember it is it's stage 1 to stage 4. Stage 1 is that there's no limitation in physical activity, and stage 4 is that they're just not able to carry out any physical activity without symptoms. And as you can imagine, fill in the gaps, and we're going to talk about it a bit more. The difference between the ACC classification and the NYHA classification is that a patient may go up and below the NYHA. What that means is that a patient might be stage 3, improve with the guideline-directed medical therapy, and then later be classification 2, whereas ACC classification is just the pure, once you go ahead, you don't come back. And let's look at the scores themselves. If you look at the NYHA, again, what Galit was saying, stage 1 is, class 1, sorry, is no limitation in physical activity, whereas class 4 is they're unable to carry out any physical activity without symptoms. If you look at the ACC, it's the initial phases is a stage 1 in which the patient is at risk of structural heart disease. Stage B is that they have structural heart disease, but without features of heart failure. Stage C is there is structural heart disease and there's been heart failure symptoms. And D is when it's refractory. So you can imagine in this classification, you're not able to move back from C to B, if that makes any sense. How that's important, we'll talk about when we come to therapy, but it's a good basic understanding that you need to have, because when we start discussing the modalities for more refractory heart failure, it's important to know which class or which stage the patient is. So going along, I'm going to rush through the next few slides, just going along how the symptoms develop. So either one, heart failure with preserved ejection fraction or reduced ejection fraction, both of them lead to increased ventricular filling pressures. There's back pressure into the lungs, and that leads to the symptoms of the dyspnea, PND, orthopnea, peripheral edema, and the lot. So at this time, I'm going to ask Nadeem. Nadeem, what's the difference between PND and orthopnea?
So orthopnea, I think it's shortness of breath that's associated with lying flat on your back. And PND, I think it's when they wake up at night because like they're short of breath. They have like these episodes where they wake up suddenly.
Excellent. You're absolutely right. Classic way patients describe this, not in New York, but in warmer conditions, is they'll wake up in the middle of the night and try to look for a window. They'll be feeling short of breath and they'll literally run to the window. Whenever a patient comes in and you see them in the ER or whatever setting you're in, the symptoms are basically in three basic assessments you need to make. And they're just a combination of the two. Is the patient in fluid overload? And does the patient have a normal cardiac output? Now, fluid overload, as you can imagine, has all the symptoms like we talked about. Difficulty breathing, dyspnea, orthopnea, PND, physical examination signs of an S3, JVP. Whereas when we are talking about a cardiac output, what are the signs you'd be expecting? Jonathan, you want to tell me if you're talking about the cardiac output?
Sorry, can you repeat the question?
Sure. So as I was saying, that when we're doing a clinical evaluation in a patient with heart failure, we're basically looking at two features, right? What's the is the patient euvolumic, hypovolumic? Does the patient have volume overload? And we're looking at what is the cardiac output. Does that make sense?
Yeah.
So everyone's able to describe what the volume overload features are. Do you know what the features of a low cardiac output might be?
So on clinical signs, I mean, low cardiac output depends on the phenotype. I mean, some people, it's really low cardiac output. It could be cold, it could be wet. So like wet versus dry, cold versus warm. And then it's like a 2x2 matrix. And they could fall in any of those four boxes usually.
What would you see commonly in the ER, for example? Let's say the patient's coming in with volume overload and a low cardiac output.
Usually warm and wet, I think, is the more common one that I've seen.
Okay. But how would you describe the feature of the low cardiac output? Like, what is the objective thing that you'll be looking at?
The echocardiogram.
Physical exam.
So, I mean, you'd see pitting edema, maybe some crackles in the lungs.
Right? So those will be the volume status, but for the cardiac output. It's more simple than you think. The answer is very simple. When I say it, you'll be like, oh, I knew that. Blood pressure and pulse, vitals.
Yeah.
Right? One of the things you always have to worry about in your heart failure patients is what the blood pressure is and how tacky they are, because again, they play in a role of what management you're going to offer during the course of hospitalization. And everything what you guys have already shared, the classic symptoms we've kind of talked about. The development of these symptoms, it's interesting to know that usually patients end up developing exertional dyspnea first. Then the elevated JVP or the orthopnea are the ones which are most predictive of the pulmonary wedge pressure, which usually suggests a left heart failure. Signs of low cardiac output, again, with what you were saying, Jonathan, were low pulse pressure, cool extremities, and again, if they're really low, reduced cognition in the wet and dry, like you were saying. And end organ damage might be a feature of low cardiac output, but it might also be caused by vascular congestion. So at this time, Tyus, I hope I'm saying your name correctly. So if I were to, if you were to get a patient in the ER, right, who you're thinking of is coming in with a heart failure exacerbation, the ER attending is already ordered basic labs, CBC, CMP, all of those. What are the three tests would you want to get in that patient in the ER?
BNP, LFTs, and lactate.
Okay. I agree with the BNP. The LFTs can help, yes. Why the lactate in a heart failure patient?
To assess for cardiogenic shock.
Okay. That will be looking more for shock, but let's talk a little bit simpler than that.
Troponin as well, to see
Okay.
if there's any ischemic causes.
That makes sense.
Creatinine, to see if there's perfusion.
Fair. Okay. So I completely agree with you, BNP, but the other things you always want to do are an EKG in every single patient and a chest X-ray. Those are three things that you absolutely do not want to miss. So Darren, can you tell me a little bit about BNP? What do you know about BNP?
Me or?
Yeah, Darren.
So BNP is a hormone that's secreted from the right atrium when it's overloaded. When the right atrium is stretched, it secretes more of the hormone, and it's a sign of volume overload.
So tell me a little bit about what makes the BNP change. Like, how do you, like, what's the sensitivity? What's the negative predictive value? What makes it go up erroneously, and when would it be low erroneously?
I mean, I can't really comment on the sensitivity and specificity, but I can comment that it does go up when someone is volume overloaded.
Okay.
At least it can't really differentiate between left versus right heart failure, but I know that it can at least indicate some sort of volume overload in that sense. So I know it goes up in volume overload, and when it's not, it goes down.
Not the down part. The down part we'll talk about, but yes. So basically, BNP is a sensitive test. It actually has a very high negative predictive value as well. As you were saying, it does go up in heart failure, right? When volume overload is low. But BNP can be erroneously low in obese individuals or individuals with higher BMIs. It's something that you need to know. The other part is BNP can be erroneously high in patients with kidney failure or older, and sometimes in females. So may not correlate clinically. The main use of BNP, or how you'd use it, is to differentiate cardiac from pulmonary causes of BNP elevation. You typically do not expect BNP to be elevated in patients with shortness of breath from a pulmonary cause. Whereas from a volume overload cause, which is usually cardiac, you would expect BNP, just along with what Darren was saying. Just basic labs that you'll get. And coming down to everyone's favorite topic, let me just see who all is here. Bailey. Bailey's going to tell me that one. So everyone gets an echo in the hospital when they end up getting heart failure, right? Admitted for that. Why do you get the echo?
To assess for EF,
Okay.
and to see if there's any like wall motion abnormalities of the heart, to see how it's pumping, and any hypokinesis that can further contribute to volume overload.
All right, good job. Yeah, you're correct. So whenever we do a echo in the hospital, you're first doing it for diagnostic purposes, right? You want to look at if there's diastolic dysfunction, what the EF is. It provides the information about the actual beating of the heart, if there's any regional wall motion abnormality. It also can give you a suggestive idea of the cause of the heart failure. Classic examples being ischemic. You will have locational or regional wall motion versus Takotsubo. Sometimes you'll have more of a global hypokinesis, which would be suggestive of that. It is how I like to think of the echo, and is that it's the test that tells you what to really ask the cardiologist, if that makes any sense. You get an echo, you get apical hypokinesis, right? What do you do with that? Well, you're going to call the cardiologist and see if the patient's fit for a cath. If you do the echo, you get global hypokinesis and you're thinking more Takotsubo. The conversation might be, when was the last cath? Do we really need to do another one? Or do we just treat as of now and see how the patient does? Does that make sense? I see some nodding heads, yes. The others' cameras are off. Okay. We kind of talked about this already. Now coming to the main point and medical therapy when it comes to systolic heart failure. Anytime you have a patient with systolic heart failure, treatment is directed at two things. First, dealing with the volume overload. And again, I'm focusing on the inpatient side of things, is treating the acute volume overload and then putting the patient on what guideline-directed therapy might be. So let me see, Tina again. And for the people who I'm picking at, I'm sorry, you're just the ones who are on my screen in the front. So that's the only reason if I'm not asking someone else. Tina, what's the cornerstone medical therapy or one drug that you know is given to almost every heart failure patient?
I'd say Lasix.
Okay, you're absolutely right. Let me reframe that question. Other than diuretics.
Beta blockers.
Okay, beta blockers. What else?
Like an ACE or an ARB.
ACE or an ARB. Any other medication that you know of?
Yeah, like spironolactone sometimes I've seen.
Good job. And do you know of any new medication which has come out in the last 3 or 4 years?
Oh, interesting.
Good job. Okay. So let's start with the ACE inhibitors. So ACE inhibitors have been the cornerstone of therapy for the longest time. I can't tell you the number of years, honestly. They reduce both mortality and morbidity. And with the advent of Entresto in today's date, we are leaning towards Entresto more and more, and we'll come to the why. But that doesn't mean that the ACE inhibitors have come out, come out of favor, or are any less used. How they work, you all know. As the term suggests, ACE inhibitors, they block the conversion of angiotensin 1 into 2. There's always a conversation that what dosage of ACE inhibitors to start the patient on. Because one of the things you're worried about is hypotension. The Atlas trial, which was done, basically looked at the difference between high and low dose ACE inhibitors used. They did find that the high dose lisinopril was associated with a reduction in the endpoint of mortality, but we'll come to the advantage of doing dual therapies or adding second agents before trying to maximize one drug first. And the consensus always is to up-titrate the dosage till the maximum the patient can tolerate. Nadeem, do you want to tell me common side effects of ACE inhibitors?
Sometimes they can cause a cough.
Yes, excellent.
They can also cause hyperkalemia.
Okay. And
they can worsen
one
AKI.
life-threatening or one more severe adverse reaction.
Angioedema.
Excellent. So the three common side effects that you need to be worried about with ACE inhibitors are kidney dysfunction, ACE inhibitor cause, and angioedema. Hyperkalemia is also another one, absolutely. In the hospital, when a patient gets admitted, and this you end up seeing a lot, that patients get admitted, they have a little bit of AKI, and patients don't end up getting the ACE inhibitors for that reason. So if the patient has significant AKI, it's reasonable to hold the ACE at the initial phase, diurese the patient, and then start it immediately as you can. But just by consensus, you should be giving the patient an ACE inhibitor as long as the creatinine is less than 2.5. This I'm quoting from your mix app, what they recommend that you should be doing. But again, every patient's different, and you might be in a different setting when you're treating your own particular patient. Hyperkalemia, as Nadeem was saying, is also another significant issue when it comes to use of ACE inhibitors and also ARBs. And it's particularly an issue when it comes to patients with kidney disease. Patients who develop these side effects from ACE inhibitors, particularly the angioedema, get transferred to an ARB. ARB don't have that much of an issue with angioedema, but rare cases are still reported. Now, coming to Entresto, and let me see if Raj, okay, I see Raj. What do you know about Entresto? What's the medication?
Isn't Entresto a combination of two things, an ACE inhibitor and a...
Ampicillin. Okay, I get that one wrong too, so I'll give you that. Do you know what nephrosilin is?
I know it's something. It doesn't it assist with diuresis? I'm not entirely sure.
So let's see if someone else can help you. Jonathan, can you help with that one? What's nephrosilin?
Yeah, so I think that's responsible for breaking down the natriuretic peptide. So if you inhibit the breakdown of BNP, then that will be pro-diuretic.
Excellent. You're absolutely right. So it's an endopeptidase. The drug itself is a nephrosilin inhibitor, and by inhibiting the breakdown of your natriuretic peptides and bradykinin, you're basically increasing diuresis and myocardial relaxation. And why it's becoming so favorably used now is the Paradigm heart failure trial. There have been sub-trials into this also as well. And they basically found a mortality benefit compared to an ACE inhibitor when used alone. The main issues when it came to this trial were hypotension and kidney dysfunction, which may often lead for patients to get disqualified. Now, asking a very practical question, because I've seen this done incorrectly a couple of times in the hospital. Let's say you have a patient on lisinopril. Let's say on Monday you have a patient on lisinopril and we're rounding, and you end up deciding that you want to start this patient on Entresto. What are the things you have to do? So Raj, that one's for you again.
Right. Can you repeat that question?
Okay, let's say you have a patient on an ACE inhibitor, lisinopril, and we finished rounds, and I said, why not start this patient on Entresto? What are the different things you have to look at? And when can you start the patient on Entresto?
Well, if they're already on an ACE inhibitor, you're going to introduce an ARB now. So you're going to kind of have that like dual effect. So you'd want to look for signs of like hypotension, also kidney function. I don't know exactly how long you'd have to wait to start, but my thought process would be to stop the ACE inhibitor before you start the Entresto.
Excellent. That's a very good answer. Darren, do you know how long do you have to wait?
How long to wait for which? Sorry,
transitioning from an ACE inhibitor to an Entresto. So Raj was telling us that you have to look out if the patient's kidney function and hypotension, but he didn't know how long you wait between stopping the ACE inhibitor and starting the Entresto.
I don't know a specific answer, but if I had to guess, maybe 2 weeks.
So 36 hours.
Yeah, I was just on cards and I just got that question asked. There's like 30, 48 hours, right?
Yeah, it's 36 hours the minimum. And this is important because what happens is it's something you need to know, because this might happen on daily rounds with you. You'll find a note from the cardiologist saying, stop lisinopril, start patient on Entresto. This is something that you need to know, that you have to wait for 36 hours. You need to see if the patient is hypotensive or not. And during this transition phase, needing to get daily BMPs to look for what kidney function is doing. Make sense? So again, practical thing, which we really didn't think about initially, but something you all need to know. So I'm going to have a question on the next slide. Let me see who's going to do that for us. You want to do this question for us?
Sorry, you said Bruno?
Yeah.
Okay, so we have a 72-year-old female evaluated during a follow-up visit. She has a 3-year history of heart failure with a left ventricular ejection fraction of 25%, in Nyha class 3 symptoms. She has an ICD, reports manageable lightheadedness with standing. Medications are lisinopril, carvedilol, spironolactone, and maximally tolerated doses. Physical exam, BP 98/64, heart rate 68, CVP of 6, S3 is present, lungs are clear. There is no lower extremity edema. Which of the following is the most appropriate management? Let me think about it. So,
It's a tough question. That's why I chose it, because the simple ones I know all of you will get.
Okay, she's on lisinopril, carvedilol, spironolactone. So I would say, because her blood pressure is really low right now, but it's a tough question, tough question.
That's okay. You want to pass it to one of your friends, you can pick one. You can pick your friend.
No, I would just I would say maybe E, or no, or maybe maybe E, just to continue your math.
Bailey, you want to take a try at that one?
Honestly, I don't know if I have much more to offer. I was thinking the same thing, or like possibly D.
So discontinue lisinopril and add Entresto. Okay.
I really have no idea.
I think it's D2.
Richard, what did you say? Sorry.
I think it's D2. You should trial the Entresto, and if the pressure lowers, then you can talk about switching it. But the mortality benefit's there. So
let's get one more opinion. Darren?
I would also say D2 because ivabradine is also, it lowers the heart rate even more. And given the fact that this person has lightheadedness and he has like orthostatic symptoms, I would try to go against adding ivabradine, but I would also discontinue the lisinopril as well.
All right. So you guys picked on the right points. Bruno, you got the answer correct. The answer is continue current management, and I'll try to show you how the examiner is trying to trick you. I've highlighted the two portions, which are the two distractors. Okay, they actually gave you in the symptomology that she's orthostatic. That first sentence, if you see that she reports manageable lightheadedness with standing, and they gave you somewhat of hypotension, 98/64. For your exams, I know boards are 2 years away for you guys, but still the answer for this one would be continue current medications. I personally, when I did this question for myself, I also chose D, but this was a tough question for for me also. So I thought it's a good one to discuss. Let's come to the next medication, beta blockers. Important to know, beta blockers should be initiated in all patients. They're important because they improve remodeling, increase ejection fraction, reduce hospitalization when added to ACE inhibitors and diuretics. In contrast to ACEs, they don't have a class effect. So the three agents with mortality benefits are your Coreg, bisoprolol, and metoprolol, the long-acting, not the short-acting. And very important for you to know that they should be initiated only when the patient is euvolemic or nearly euvolemic. What that means is when you have a patient coming in to the ER in volume overload status, you stop the beta blocker. Everyone follow me for that one? A few nod heads. Okay. Volume overload, patient coming in the ER, initially you stop the beta blocker, you diurese the patient first. And then you have a conversation on when to restart the beta blocker. This is important. Have negative inotropic properties, and it may exacerbate heart failure in patients with volume overload. And that's the reason why you do it. They should be up titrated over weeks. They're not something that you up titrate quickly. And on your discharge medication checklist, which I know you guys have maybe started doing, but you'll be doing a lot more next year in heart failures, always try to get the patient on a beta blocker before they go. As you already know, beta blockers, you have to be a little careful in patients with significant pulmonary disease, but at the same time, for heart failure, they're essentially very important. Combination of them with the hallmark is the combination between the ACE and the beta blocker, which is important. Now, there's always a conversation which one to start first. There's actually not a science behind it. It's either drug can be started first as long as the patient is euvolemic. You want to make the decision based on what the patient base features are. Let's say the patient has known CAD or atrial fibrillation, might be more sensible to do the beta blocker first. Let's say the patient has diabetes or known has some renal issues that you want to do a renoprotective function, then an ACE inhibitor might be more reasonable. But it's the combination therapy that you're truly aiming for. Does that make sense? All right, let's see who's going to do the next question. Alberto, you want to do the next question?
Sure. So it says a 72-year-old man is evaluated in the hospital for heart failure. In the past month, he has developed progressive dyspnea, such that he cannot walk 50 meters without stopping to catch his breath. He has a history of hypertension and ischemic cardiomyopathy. During the hospitalization, a perfusion imaging study demonstrated no ischemia, and an echocardiogram revealed a left ventricular ejection fraction of 20%. Medications are aspirin, ramipril, isosorbide mononitrate, and furosemide. On physical examination, the patient is febrile. Blood pressure is 120/68, pulse rate 73, and respiration rate 22. The estimated central venous pressure is 9. A paradoxical split S2 and then S3 are present. Lungs are clear to auscultation at 12 leads. EKG is shown.
What do you see on the EKG?
Okay, just like we see an irregular rhythm. I cannot see P wave clearly.
It's a poor artifact, but it is irregular. You're right.
Yeah, regularly irregular. Then we see a white QRS with left bundle branch morphology.
Good.
And then, yeah, so the axis is deviated to the left.
Good. So left axis.
Yeah.
So LBB, widened QRS, AFib, and you said left axis, correct?
Yeah.
So this is your question.
Okay, in addition to diuresis, which of the following is the most appropriate treatment before discharge?
So the options are beta blocker,
ivabradine, cardiac resynchronization therapy, and implantable cardioverter defibrillator placement.
I'll open the question again for you if you want to read the. So I'll remind you of your options: beta blocker, ivabradine, CRT, or ICD.
Okay, so I think the patient had an AFib on the EKG, plus the left bundle branch block we saw. Heart rate currently is 73, and patient has heart failure with reduced ejection fraction. I would like to add the carvedilol first.
Beta blocker.
Beta blocker.
That's the one you're choosing?
Yeah.
What did the EKG show?
So the left bundle branch block? The
left bundle branch block, widened QRS, AFib,
and the left axis deviation.
All right. So your answer is?
So the beta blocker.
Well, let's get your colleagues' opinions. Galit, you want to tell me what your answer would be? Follow the question or no?
Yeah, I was gonna say beta blocker as well, so I'm guessing that's not right. But I don't know.
Let's see who else is there. Mohammed.
So I was just looking at the ejection fraction of 20%. I think I read that if the ejection fraction is less than 35% and ICD is recommended, so I guess I'll go with that one.
And then I see two people sitting together, Jasmine and Adrian. So both of you can get one more.
I was gonna say A as well, beta blocker.
Jasmine, what about you?
Yeah.
All right. So the answer is actually beta blocker. So Mohammed, I'm gonna discuss this with you. So the answer is beta blocker here. Maybe Raj, you can tell us why the answer wouldn't be an ICD.
There's no, I mean, I would try to convert the rhythm on its own and manage. I mean, I'm not too sure, but like I wouldn't have gone for that just because, like, I know you can address heart failure and atrial fibrillation with a beta blocker. So I wasn't even looking at the ICD, but I'm not aware if there's like an indication based on EF for that.
Okay. Jonathan, why is the answer not CRT or ICD?
So I think an ICD would be indicated. It just would be done outpatient with EP. It just wouldn't be done before discharge.
It'll be done outpatient, yes, but there's more to it than that. Okay.
I think with the ICD, normally don't we wait to see whether after the patient on goal-directed medical therapy, their EF improves? And if it's still low, then we consider an ICD like in a few months.
How long you wait?
3 months.
Excellent. And let's say there's one in which you wait 40 days. Do you know that one? So thank you, Nadeem. That is the main thing that I wanted you guys to think about. Whenever you have a patient with significant heart failure, so when you look at this patient, it says in the past month is when he started getting worse. On the description, they're describing an NYHA class 3 patient. They're telling you that it's heart failure with reduced ejection fraction. And on exam, they're giving you a paradoxical S2. So they're telling you that the patient is significant volume overload. They're telling you that the heart failure is significant in a basic way. Before you jump for CRT or ICD, it's important for you to know you do guideline basic therapy, guideline directed medical therapy for 90 days. If this was an ischemic cause, then you do guideline directed medical therapy for 40 days before you choose CRT or you choose ICD. The EKG in this question is this distractor because it's such a beautiful EKG. Like you can pick up the widened QRS, you can pick up the LBB. Everyone wants to jump for those. But again, if you face a question like this, it's important for you to know medications first, then jump for the CRT or the ICD. Everyone following me?
Sorry, just to double check. So it's 90 days, and if it's ischemic, 40 days.
Yes.
Gotcha.
All right. Okay. So if you post MI, you wait 40 days at least. On guideline directed therapy, do a repeat echo. If it's still reduced ejection fraction, it can be a conversation for ICD. If it's not an ischemic cause, and this guy, they clearly tell you that perfusion imaging, there's a reason why they're giving in the question that the perfusing imaging study showed no ischemia, because they don't want a gray area between 30 days and 40 days. 30 days and 90 days is significantly different. Was that Galit? Okay, let's go on.
Yeah, thank you.
Diuretics, as you all know, your hallmark medication for volume overload. Loop diuretics are preferred. Of the loop diuretics, torsemide is becoming more and more favored, but it's still not used everywhere just because of the financial burden. Target euvolemia and adjust the dose according to the volume status the patients come in. And often a conversation is trying to start the patient on double or 2.5 times the dose of diuretics on the time of admission when they come in significant volume overload. There's no difference between continuous versus bolus diuresis. In the ICU, you might have seen dopamine with diuresis. It doesn't really benefit the kidney function, but it might be beneficial if the blood pressures are low. The medications, and I'm kind of jumping through a few of the medications which are not commonly used. Digoxin. Digoxin still has a place in treatment of heart failure patients with AFib for rate control. Important for you to know, it doesn't decrease mortality in any way, but it does reduce hospitalization. And if you discontinue it, there's actually a realistic expectation of worsening of heart failure symptoms. It does not improve survival. Coming to aldosterone antagonists, your spironolactone and epinephrine, these are medications which are unfortunately underused. They're important for patients with NYHA class 2 to 4. They have proven efficacy, but the main problem that you come across with them is that of hyperkalemia. So if you're going to be initiating a patient on these medications, you do follow for your renal function in the immediate near future. Both of them are equally effective, but remember that spironolactone has more anti-androgen, anti-progesteronic side effects that may end you leaning more towards epinephrine. And remember that they're not considered diuretics in this case. They're truly as an additive medication to the regimen and not solely doing the purpose of diuretics. Or isosorbide dinitrite hydralazine combination. Important for you to know, it's been shown to have benefit in African Americans. But ACE and ARB inhibitors are still. So let's say you don't have a contraindication to use ACE or ARB. You do not choose isosorbide dinitrate or hydralazine. You use them when you can't use ACE or ARBs, or you use them in addition to ACE and ARBs. Does everyone follow me? So what they'll try to do is they'll try to put a question for you and, describing an African-American gentleman and giving the features, and they'll give you this isosorbide dinitrate hydralazine and another option of lisinopril. Always remember, ACE and ARBs are still preferred. So when you can't use them, that's when you use this.
For just blood pressure control, would you prefer like the amlodipine in an African American?
So coming to that on the next one.
Okay.
So amlodipine has not been shown to have benefit when it comes to heart failure, but they can be used only for patients for hypertension management. That was your question?
I just heard that for African Americans, like it's more preferred to give them amlodipine since they have like low renin, and typically, like genetically, like they have lower renin than Caucasians. So ACEs don't work.
That one I'd have to look into. Coming to ivabradine, less commonly used. It works on that funny channel that we've heard about. It has been shown to reduce heart failure associated hospitalization and decreases the endpoint for mortality in heart failure. It's basically used in patients who are not able to reach the rate control despite maximum beta blockages. Everyone follow me? That means you try and give patients who your expectation is 3 to 5 years at least. And this is something we should be talking about because this is something which is in the next 3 years, something you're going to be doing for almost all of your patients. Your diabetic patients with heart failure, so thinking about it, just saying that sentence, your heart failure preserved ejection fraction patients with known structural heart disease, even if they've not developed features of heart failure yet, more and more endocrinologists and cardiologists out there are now starting to recommend SGLT2 inhibitors to be initiated early for these patients. The reason for it is more and more studies, and this is an ongoing thing. Like I think the recommendation first came out last year or 2020, and it was a combined recommendation with the American Diabetes Association, and it was endorsed by ACC, basically saying to initiate in patients to reduce the risk of heart failure hospitalizations. At the end, I'm going to finish in the next few minutes. Remember that no drug really has been shown to reduce morbidity or mortality in patients with heart failure with preserved ejection fraction. The goal of therapy is the same, what we've already talked about. Treat their volume status. That is what truly will affect their mortality. Coming to your ICDs and prevention of sudden cardiac death, and we'll talk about what we was briefly speaking with the last question. Your They're recommended for patients with NYHA 2 or 3 with an EF less than 35%. And this I'm talking about ICDs. Like I was saying, and Galit, this was your question, right? You reassess 40 days after an MI and 3 months otherwise to see if the patient is applicable for an ICD placement. Basically, you're trying to prevent sudden cardiac death in these patients. And CRT is more useful, or is not more useful, is the treatment of choice in patients with a widened QRS and a left bundle branch block. Everyone following me so far? So that's what they were trying to do, the distractor with the last question. But remember, this all comes afterwards. The treatment is still guideline-directed therapy first. Strategies to prevent readmissions are, every patient, every hospital system as of today, practically every hospital system as of today, has a heart failure checklist, which patients, like either the nursing team will be doing or you guys will be doing at the time of medication reconciliations to make sure the patient goes out on the appropriate medications. There is a transitional care appointment, which is recommended across all societies, that the patient should have ideally a follow-up within 7 days of discharge. So whenever you're trying to admit a patient with a heart failure, the best thing to do, at least in our hospital system, is to put them on a heart failure pathway, which all of us have. So even if you're somehow missed to check the medication discharge list or forget to set the patient up in 7 days, what that pathway does is intimate to our cardiology team or their support staff to reach out to these patients to make sure there's a follow-up which has been done within 7 days. And I'm going to open for any questions. Anyone wants to ask me anything about this topic or anything I can help with, and then I'll return you a little bit of your time.
Yeah, I have a question.
Okay.
So if someone comes in, like I know, from my understanding, if someone comes in with heart failure, they're tachycardic, you wouldn't want to start a beta blocker, right? That's my understanding. If they also, so then what do you do in the case that they have AFib with RVR in heart failure? You still hold off on starting the beta blocker?
Think about it. You're avoiding the beta blocker for the volume overload. If they have known history of heart failure, but they've come in with AFib with RVR, you're going to do the beta blocker because you're trying to address the AFib with RVR. If they've come in with volume overload and they're in AFib, right, you're going to diurese first. That makes sense? The idea is to come near euvolemia before you do it. Now, there's a counter argument that I've had this discussion with cardiologists a lot of times. Many cardiologists don't like stopping the beta blocker, especially when the patient's been on it for a very long time. For the purpose of what we do for medicine, the recommendation is still to stop it at the time of volume overload. Does that answer your question?
Yeah, thank you.
Sorry, follow-up question. But if the AFib with RVR is decompensating the heart failure?
So if it is to the point of hemodynamic instability, if you have to use a beta blocker, you have to use a beta blocker.
Gotcha. Okay.
And it's thought that the beta blocker would help, right, with the heart failure, because if someone has heart failure but is in AFib with RVR, they're not going to have adequate filling, and so that's going to decrease their cardiac output. So we actually want to control the rate, and that'll help with their heart, like cardiac output.
Exactly. So again, your volume overload, you diurese. If it is to the point that your AFib with RVR is at that level that it's causing hemodynamic instability, and the patient you're describing to me is hemodynamically unstable. Does that make sense? In that case, when you have to use a beta blocker, you have to use it.
If a patient's hemodynamically unstable, wouldn't you, and they have AFib with RVR, wouldn't you just do cardioversion at that point?
Again, it depends on the context you're in, right? You can always try medications first, right? Think about it. You've seen patients in the ER, they'll be in the resus room. Would you immediately do cardioversion, or would you do at least one push of metoprolol 5 milligrams and see what the patient does?
Sure.
Okay? So it depends on where you are. Now, if you tell me the patient's been in the ICU for 2 days, you've been trying the beta blockers, not working, yeah, absolutely. You can have a conversation. Is there a role of cardioverting this? But it depends on the context you're in.
I had also one question about what is the current role for SGLT2 inhibitors in non-diabetic patients, especially patients that are being discharged from the hospital?
So right now, the recommendation from ADA and ACC, the last one that I'm aware of, was for diabetic patients. I know pre-diabetic patients are also slowly coming onto that list. You're not going to give a SGLT2 inhibitor to a patient who's not a diabetic generally. That make sense?
Are they also really great for weight loss too? So you kind of get like the double benefit of it.
Again, diabetic patient, yes. But the reason where this endorsement came from was it was shown, the study showed that it reduced the hospitalization or the risk of hospitalization. That's where it came up. The added benefits of what SGLT2 inhibitors would have will be there, but in this context, that was the reason.
I had a question about patients on Entresto and patients with ICDs. So if someone gets an ICD, do you continue them on the Entresto?
You still continue them on guidelines.
You keep them on that?
Yeah.
And then would you start Entresto if they like qualified for the ICD and kind of basically have both?
So think about it. If you've reached the point that an ICD has already been placed, Entresto would already be running. You make the decision of the ICD once you've had the patient on guideline therapy for the longest time, 90 days. That's what we just spoke about, right? So rarely ever will you be having a conversation, do you start the guideline therapy afterwards? If your question is that the patient was on an ACE altogether this whole time and Entresto was never even attempted, the conversation can be yes afterwards. But a typical patient, what you will see 99 out of 100 would be that that's already been tried. It's continuing. Anything else?
Can I just chime in? Because that was a great question. I got the last part of it. So Sarah, it has to be maximally tolerated guideline-directed medical therapy, right? So at maximally tolerated doses, which includes everything that you guys have studied today. And you've got to have been on that for 3 months on the maximum doses. And ICD is really for primary prevention, right? So if you've already had an event like a VT, you may have an ICD from that. But this is for primary prevention that you'll put in an ICD at that point if you haven't recovered your EF to over 35%. So, does that make sense?
Yes. I also, because I was also from that first question that we had on the Entresto and ICD, because I was just asking because I was like, oh, is that a way I can easily rule out that answer? Essentially, like, I know there was a lot of other factors with that question.
I'll be very honest. Yeah, this one.
Because she was already on, she already had the ICD. You know, so on that question, regardless of the hypotension and everything, you know, would she be a candidate to start the Entresto?
So if they had not given these two features for the distractors, which I've highlighted, you can make that argument. It would never be that you do ACE and Entresto together. So your option B is out, your option A is out. It comes down to between D and E in all realistic, at least based on the question they've given us. If those two were not there and you wanted to tell me that they've removed the first sentence and given a blood pressure of 124/82, yeah.
Okay, thank you.
Sorry, while we're just on this question, I think Darren had mentioned about the ivabradine regarding the heart rate. When would you add that? Because I know it's typically used for like continued symptoms. So if this patient's heart rate was at the appropriate level, could you also add that in addition to the valsartan and
the target heart rate for patients is 60, right? With heart failure. Ivabradine is added once you've done maximal therapy of the beta blocker and you've not gotten sufficient heart rate control. Again, given the question that we have here, ivabradine wouldn't be the option because there's better options there anyways. If in a real patient that we're talking more on a practical sense, the conversation would be that are we at the maximal doses of beta blocker yet? And then do we need to add ivabradine?
Yeah, let me just chime in one more time, Raj, because ivabradine actually shows up on every ABIM for some reason. And so that even if you never see it in practice, it's always on the boards. And the indication is you've got a maximally uptitrated beta blocker, which is 200 mg of metoprolol. It's a lot of metoprolol. And you still haven't gotten the heart rate under 70. So it's a heart rate that's over 70 with 200 mg of metoprolol or 25 BID of Coreg, or I don't even know what the bisoprolol dosing is, but I'm sure it's out there and some cardiologist knows. And you still haven't hit under 70, then you do ivabradine. And ivabradine is a funny channel, something. I've literally never seen anyone on it. And then the other thing, you know, this is sort of more historic about Entresto, is that when the paradigm heart failure trial first came out in 2015, you guys were probably still not in med school even, the biggest problem with Entresto was the amount of hypotension, orthostasis, and hyperkalemia it was causing. And that's why questions like this are on the board, because they want you to be aware that there's multiple side effects that your patient may not tolerate. And so even though it has great mortality, morbidity outcomes, there are feared side effects. You don't want your patient syncopizing from being on Entresto.
I also just want to make a comment about the boards, which is more for the third years than the first years. The boards are never asking for the correct answer. They're asking for the best answer, which means sometimes it's not even up to date because something changed, but it's a little bit old. And that's why they always say the best answer. And that trips up a lot of people because they want to be so precise.
Going along with what Dr. Singh was saying, with the paradigm heart failure trial, I kind of slipped through this, but 16.7% of the participants actually had symptomatic hypotension. So it was a significant issue during the trial.
I mean, you guys have seen this on the wards, right? You start Entresto, the next day the blood pressure is 90 systolic, and you're like, all right, let's back off. I mean, June, we did this with the patient at the end of the hallway last week. Yeah.
Okay, I think I'm almost out of time. Thank you so much for attending.